Okay, we're back from our break. We're going to start our discussion on dealing with, assessing a little bit, but primarily managing airway. And we're going to include intubation as the bulk of this lecture, but some basic things like suction and other tools. I do want you to review from your lab shell inside the skills videos this list of videos as needed. So if you are fine with inserting a OPA, then you don't need to review that video so much. If you need some pointers on it, you can certainly review, and those are all available again in the lab shell. All right, so let's say we're dealing with the patient's airway and it's got some type of obstruction. There's lots of different types. So we think of like foreign body airway obstruction as one type, but there's also things like blood and vomit, and then some foreign body stuff like soda or beer caps and such. That'll be a problem. So some things that we remember when we're clearing the airway, we've got a couple different tools, but we start off with just our kind of basic, and that could be a finger sweep, generally no further than we can see, and we want to make sure we're protecting our fingers as we do such. When we don't suction our patient appropriately and we move on to airway, the patient is likely going to die. Quick review of suction equipment. You have two types, Yankauer and whistle tip. Whistle tip is utilized for our patients that are intubated or other cases when the suction catheter or the Yankauer is not available. So let me just kind of highlight this for us. So I think you're probably aware of the Yankauer there. Techniques for suctioning. So one of the things we want to make sure that we're aware of as a pitfall, a downside to this, is suctioning removes airway oxygen. And so when we're doing this, we want to kind of limit the amount of suction time that we're using, but I would say that we're going to do this or until clear. All right. So the adult, we're going to go up to 15 seconds. It is important in children and infants, 10 to 5 seconds is what we're looking at. So this one until clear is difficult, but something happens not just in removing the oxygen, which is causing our patient to go to the hypoxic realm, but we can also stimulate the vagus nerve. And as you recall, the vagus nerve is a cranial nerve, and as a cranial nerve, it's going to actually represent the parasympathetic nervous system. And in children, that can cause a dramatic decrease in heart rate coupled with their hypoxic state, and that can lead to death. Lots of causes for our foreign and intrinsic airway obstructions, but we're going to focus actually on these two things. I think that you have heard about these ideas as a basic, but maybe not a bit on this, and they are problematic for the paramedic. So let's define them. So laryngeal spasm is going to be a spasming or a closing. It's not just kind of opening and closing, it's fully closed now of the vocal cords together. This closure is dangerous because it completely occludes the airway. Nothing's going to move from upper airway into lower airway. And common causes, this is one we'll probably be most concerned about, are intubation trauma in which we're bouncing the tube off of those structures, the false vocal cords, the piriform, fossa, and such, and that causes swelling, bleeding, and aggravates the larynx so that the vocal cords close. Laryngeal edema is a narrowing of the airway, and you can just imagine that's true for epiglottitis, anaphylaxis, and inhalation injuries. Relief of laryngeal spasm and edema, specifically laryngeal spasm, can be very difficult and is not fully relied upon. So we do need to know that that's happening and identify it quickly and be very careful in preventing it. Aggressive ventilation can help, but the downside is going to be that the ventilation that's increased is going to decrease the oxygen going into the lungs, perhaps if it opens up, and that pressure that it's working against is going to send that into the stomach, leading to a risk of aspiration and also a decrease perhaps in blood pressure and rebound shock signs. Forceful upward jaw pull is going to rely on our ability to manipulate the hyoid bone through the tongue, is what you're really pulling up with the jaw. And then it's going to also impact moving at the epiglottis. Something that's very important here as well is this could reoccur. So not necessarily that perhaps this happens to you, but if a patient is choking and they relieve through maybe 911 emergency medical dispatch instructions, through 911, they're told how to do this, or their friend is told how to do this, and they clear the thing, and you get there and they say, oh, it cleared, I feel fine, they're coughing a little bit. Well, those patients are at risk of this happening again a little bit later. Generally happens within a 30-minute time period. And so you do need to advocate for your patients. Maybe they don't want to go in. You don't want to take them in, perhaps. Maybe it's been a rough week. But unfortunately, if we leave them at home, they could die. Laryngeal injuries and trauma are not super common, but when they happen, they are a concern, because if we close off that airway again, as we close off that airway, the patient is not going to be able to ventilate and not going to have respiration and not going to clear CO2. So some examples of this could include, as kind of listed there, penetrating injuries and such, crush injuries, but clothesline injuries where they maybe a four-wheeler, a person on a four-wheeler is riding and they don't see a fence line and they run into it and it catches them right on the throat. Maybe not a decapitation, but it'll fracture their larynx. I'm sorry, their trachea and potentially their larynx. So recognition and treatment of our airway obstructions, this falls back to BLS, to be honest with you. And so just remember, if the patient can talk or can cough, let them cough until they need your help, right? And you can ask, but always be prepared to intervene as that patient is trying to clear the airway. Severe obstruction occurs as a split between the two. The mild is they could probably talk somewhat, but severe obstruction is they're going to have an inability to talk and their cough is going to be weak. So they're giving up. And let's think about that. When you cough, you forcefully exhale, right? So what muscles do you think you're using? Those weak intercostals, internal intercostals in these patients. And just generally with severe obstruction, we're going to immediately intervene. Okay, so a responsive patient that's choking, we're going to, specifically a responsive patient, we're going to start moving towards our use of a Heimlich maneuver. If they're unconscious, we will use other mechanisms as well. So Heimlich maneuver is going to forcefully, artificially create a cough, and that should expel this content into their airway. If the patient goes unconscious and you lay them down, protecting them from injury, when you do chest compressions or chest thrusts, you need to frequently reassess the mouth to make sure that whatever was in there didn't pop out and then you missed it and you kept doing these things. If they take a deep breath inward, they may suck this thing right back down into their airway. So if the patient's unconscious, we're going to move to chest compressions, 30 chest compressions with our rescuers, and we'll try to ventilate as much as possible. If we see something, again, we'll either suction or use our fingers to remove it. And as we use our fingers to remove it, remember that we don't feel back or insert our fingers further than we can see. And we want to be cognizant of the idea that we have our hands in somebody's mouth and they have teeth, possibly. All right, if those basic techniques don't work, then a paramedic can utilize the McGill forceps, pictured here. The McGill forceps are going to be really useful, and you can see the design, that movement. They have little eyelets at the very bottom on the distal portion of the device, but that's designed really to fit right into the lower airway and remove any objects that are a little bit harder to get. You do couple this with direct visualization of the airway using a laryngoscope and trying to grab this device. Skill drill 15-8 is going to cover the steps of using McGill forceps. A note on dental appliances. There's lots of different forms of artificial dentation or dental changes that we need to be aware of. Lower on the list is probably going to be our braces, but as patients wear things like Invisalign, where the braces are clear and they attach to the little bumps on their teeth rather than the wires and the bands that go on there, that could fall off, and it's a low risk, but that could fall off and cause an airway obstruction. When we're dealing with dentures and bridges, we want to make sure that we're trying not to lose the patency of our face when we're ventilating our patients. And if you remove dentures, they become edentate, their mouth changes, and if you think of somebody who doesn't have their dentures in, the face, the cheeks move inward, and that's really hard to get a seal on with your BVM, but more on that later. So determine whether it's loose or fits. If it fits well and it's secured, leave it in place. If it's loose, then pull it out and save it so that it can be taken to the hospital. And remember that this patient, if they survive the incident, that's a lot of money. Braces and bridges are not cheap. You know what this is, and you know how to insert it. So what I'm just going to cover very briefly orally is the idea that it is a rescue airway. It does have advantages and disadvantages. Advantages, it's a blind insertion, and it comes in a large array of sizes from infant to large adult. Disadvantages, the primary disadvantage is it's a little bit difficult to insert if you don't know what you're doing, so you need to practice in your off time to make sure you've got this down. But the distal portion, let's just kind of remind ourselves where this sits. The distal portion here sits inside the esophagus. And when you're using this device, you really should not forcefully hold it in place. You should loosely hold this device in place so that it'll seat perfectly, with this pointing basically down into the trachea. If the person vomits forcefully, though, this could move. And when it moves, it acts as a satellite dish to send things back down into the lungs. Multi-lumen airways, there's combi tubes pictured here, but there's also the King and the BTL that could be useful or testable. I would encourage you to get familiar with the King, although we don't have a large amount of discussion on it. It's becoming a little bit more popular as we go out there. So some ideas, obviously this is easy to put in, it's blind insertion. Downsizes specifically for our combi tube is it comes in a limited set of sizes, only 2 sizes, and they don't necessarily fit all. Do you recall our critical patient management lecture? I hope so. In that, we talked about the idea that when you're dealing with critical patients, you're projecting their needs in the future based on their condition and based on your experience with such calls, right? If you're a person who has run calls with patients that are CHFers before CPAP was integrated, and you are successful in nasal intubation, you're probably going to work hard at getting that nasal intubation very early on because it can save you a lot. If you haven't had a good experience with a CHF and they start to crash, you may elect to move these things on a little bit further sooner in your algorithm. So I want you to look at these, predicting the need for intubation. There's many reasons outside of this, but in general, I give you these tips. So the patient perhaps is awake now, but likely to decrease their mentation because of their injury. The work of breathing is severe and not maintainable. And remember, if they're forcefully exhaling and they're using all these accessory muscles, at some point they fail, they crash, the person goes into respiratory failure and ultimately arrest. Perhaps you got a patient that's combative and their mental status is impeding your ability to give airway control. Remember, combative patients have a decreased level on essentially their mental function, and hypoxia is a common cause for combativeness in patients that aren't intoxicated or just don't like you. A GCS less than an 8 is an indication for aggressive airway management, and perhaps we're thinking about injury projection into the future as mentioned, and we've got some tools, some of them not in New Mexico, but they're taught here. All right, so when we're dealing with our patients that have airway problems, some things that we want to identify, some terms here, are failed versus crashed airways, right? So a failed airway means that things that you've done have not worked. And a crash airway is in a hurry. The patient is crashing. patient is crashing. So the way this algorithm, if we wanted to make one up, is you look at the patient's condition and you look at but primarily starting with BVM. Okay. So if you are BVMing the patient, you have good compliance, that means that you have a little bit of time, right? This is not a crash. This patient's sick, but you have a little bit of time that could be useful. And when we have a little bit of time, perhaps we're looking at doing something like endotracheal intubation. Okay. Or really, you would probably see it as OTI, Orotracheal Intubation. All right, so if we have time, so BVM is, let's say, okay, it's compliant and we have good basic airway mechanisms, we'll probably move to the OTI. If the BVM is failing and it's not working well, we're probably going to go for whatever airway we can. And one of the first things we might consider is, does an LMA work or supraglottic? Or is it no? No. Or is it perhaps something that is going to require a crike? All right. So these are crash airways. If we try OTI and we intubate the patient generally 3 times and we're unsuccessful, then that suddenly becomes a failed airway and we'll need to go aggressively into any tool that you have. Okay, so failed versus crash airways. We'll see that in a moment. Some ideas associated with advanced airway management. So a common mistake is not providing a patent airway in your very early onset of assessment and using basic techniques first. You should never, never forgo BVM so that you can get a tube. You should never spend more than that 30-second window inside their airway before you ventilate, because that's a bit of arrogance that will probably get your patients killed. So predicting difficult airways. So difficult airways are airways that we are probably going to spend more time trying to get the airway, or there are very clear indications that this airway may not go well. So there are some anatomical findings, so congenital abnormalities are a concern, so history is going to give us that. A patient that's recently had surgery might be a difficult airway, and one of the reasons for that is if they were intubated, being intubated again is a little harder, and there's probably swelling in the airway and many different reasons. Trauma could be an indicator of difficult airway, specifically something of the torso or the head and face and neck, obviously. And then neoplastic diseases are diseases in which we have structures that are blocking that airway. Could be a tumor or so. So there's an acronym that has been utilized pretty heavily, and it's out of your textbook as well. It's called LEMON, and this is how we assess an airway to determine whether it is going to be difficult, right? So use to assess. So we're going to look externally, so we have them open their mouth and we look into their airway to determine if we can see anything, and then we're looking for dentures and stuff like that. We're going to evaluate 332, and I'll show you that in just a minute. We're also going to give a Malapati score to our patients, which kind of indicates how hard or easy this will be. We want to always check for obstructions, and then neck mobility is going to be a concern in our patients. We position heads differently in adults and children, and sometimes positioning is not attainable. So look externally, number one. So we're going to look at patients that just kind of short, thick necks, looking for scars. Maybe they have a trach before, which is going to be difficult for you. Morbid obesity and dental conditions. And the morbid obesity is important because that person might need a little bit different approach to positioning their airway. So here's the 332 rule. So number 2 on our list are really looking at E. Right, this is the E section. So we're evaluating 332. So you basically measure this as is portrayed here. So you want to look for 3 fingers as the width of how far they can open their mouth. That gives you enough room to manipulate into their airway without fulcruming on teeth and such. Also, number 3 is 3 fingers to the size of the mandible, right? So we're checking to see how far away from the neck the chin is. So 3 fingers would be a good indicator. And then we're looking at the distance from the hyoid bone to the thyroid, and that's going to be at the base of the tongue, kind of where that crease is of your face and your neck, down to the thyroid notch, right? So the thyroid notch kind of sits like that, and underneath of it you can actually see it You can actually see it here. That's the cricoid membrane. If those things are achieved, then you probably have a pretty good chance at the airway. Then there's the Malampati score. The Malampati score is going to look at classifications based on your visualization. So you're going to have them open their mouth and you're going to look. Class 1, as you can see, basically everything in the airway. And that means that it's not a tight opening for us to try and get into. Class 2 might be a little bit more difficult. The posterior pharynx is partially exposed, right? So that's back here. And a lot of times that's the size of the tongue. And if they're sticking their tongue out, they may not necessarily in class 2 be problematic because you're going to manipulate their tongue anyways. Classes 3 and 4 are going to identify potential difficult airways. So class 3, as you can see, just a little bit. Primarily you're looking at the top of the uvula being exposed but not the whole uvula. And then class 4 is you don't see anything, and this is a difficult intubation. Always look for obstructions within the airway to determine how you're going to place this tube and how visualization or direct laryngoscopy might go. And then neck mobility is important, and so our patients need to be in a sniffing position. So basically pushing their head forward and sniffing a flower is the best way to think of it. A lot of times though we have a hard time intubating patients because in general intubation you're going to do a head tilt chin lift so you can get the right angle to look in the airway, but that is impossible in a trauma patient if they have a cervical spine injury because we manipulate their neck. That could cause an issue for them. So we need to practice in class means of intubating patients with decreased neck mobility. And then finally, what I want to kind of throw out here is we do want to decrease their neck mobility post intubation, right? Because we don't want to lose that tube. There are a lot of techniques and a lot of tools that can be utilized. Something you think about though is when you're intubating somebody, you should not exceed 30 seconds into their airway. And that's assuming that they're pre-oxygenated, right? So do not go greater than 30 seconds. On your attempts, go back to a BVM if you've gotten past 30 seconds. Improper tube placement can be fatal if not recognized. If you put the tube in the wrong area, the esophagus, and you recognize it, remove the tube, ventilate, get another tube, get things ready, and try again. It's not the end of the world at that point as long as it is recognized. Here's a list of the skills drills associated with these different types of tools that you have available for you. And we're going to briefly cover all of these as well. You'll see these things in lab. We'll practice some of these things in term 1, but practice them primarily later in term 2 with respiratory and lab 2. So that's available for your slides so you can write those skills drills down. All right, so let's talk about endotracheal intubation, the big fun stuff. So some advantages to this. It's going to secure the airway. The tube is going to pass through and be just deep to the vocal cords, and so when inflated, it'll be very useful in keeping the aspiration risk low. It is also another route for medication pushes, so not all medications, but some medicines can be pushed directly into the ET tube for absorption into the tissue. And it's not just looking at things like albuterol, we're looking at primarily some really, really powerful ALS drugs. Disadvantages, it needs to be practiced and special equipment is necessary. And even with all of those things, sometimes our Malampati score or our lemon, right? So our lemon would give us our assessment. Could just be not in your favor. Complications, serious complications. So could be some airway bleeding, hypoxia could ensue. We've talked about these things. Vocal cord damage. So doing this wrong on a patient who uses their voice for a living could be certainly a big deal for you because if you tear their vocal cords, their voice may never be the same. And so that singer has effectively lost their job and you'll probably be evaluated on your performance. Now, two other things that we haven't talked about here are going to be mucosal necrosis. So if that tissue inside the airway is dead, it's not going to be as pliable. And then barotrauma. Barotrauma is a risk because as soon as we start ventilating, or maybe there's tears in the trachea, some of those things, the patient will probably have, again, a bad outcome as you try to manage them. Basic structures of the tubes. I hope you have this part down. The 15 millimeter adapter is important. That's just something to be aware of. The 15 millimeter adapter is the right size to connect to the BVM, my beautiful BVM. That's the right size. So the adapter is important. When you're looking for tools to connect maybe inline nebs, 15 millimeter adapters are important. ET tubes come in a large range of sizes from 2.5 to 9 on the inside, or their lumen, and then 12 to 32 centimeters in length total. Pediatric patients, just on a note, they're going to be utilizing generally uncuffed ET tubes, and I do realize that New Mexico has removed pediatric intubation from the scope of practice for the paramedic, but it is expected for National Registry that you know these parameters, so please do not write them off, assuming that we don't do it here, so it's okay. So with our patients, a lot of times because of that structure of the trachea, uncuffed tubes are preferred. There are ways to determine the size of tube for your patient. There's some specific ways. So one way is to, and this is true for adults as well, you're going to have just an assessment of the internal diameter of the nostril, and that of their nostril, and the dominant nostril, the larger nostril, is about the size of the glottic opening. And then the diameter of the little finger, or size of the thumbnail, approximates airway size as well. And realize what you're measuring here, if we go back to this slide here, is going to be the millimeters. So you do need to memorize the idea that the inside diameter is in millimeters and the outside length is in centimeters. But they don't really come in like a 2.5, 15 centimeter tube. So it's standardized, and you're measuring primarily the inside diameter, which will give you the external length. Now, when you're intubating a patient, you're going to set up all of your equipment, including the size you think it's going to be, one size smaller and one size larger, so that when you get into that site and you visualize, you never want to take your eyes off of that because you may lose it forever. You want to have the other tube ready so that you can put it in if the first one fails. I do want to note on blade types here, not necessarily how the whole handle works, but we have two blade types, and we're going to use the term Miller. But there's also a Wisconsin blade, which is actually a little bit different than just the regular straight blade, which is the Miller. So straight blades are designed to extend past the epiglottis and physically lift the epiglottis up so that it's out of the way and you can look at the structure to pass your tube, which is not the same for our other device. So straight Miller blade. The curved blade is called the Macintosh blade, and so one way to think about it, I believe I got this from Kathy in our class as a student, but when you're looking at the Mac blade, just imagine that this is curved like a Macintosh apple. Beautiful apple. So this is a little bit different. So it uses indirect manipulation of the structures around the hyoid bone to lift up the epiglottis so that you can visualize. The tip of this is going to be placed right here, this tip here, a little bit more rigid than the straight blade. This is going to be placed into the vallecula. And remember that space is between the tongue and the epiglottis. Laryngoscope blades come in a variety of sizes as well, based also on their straight or Macintosh curve blade. So you do need to know straight is Miller, Macintosh is curve. Something that you'll come to know is that the use of the blade is a preference that you're going to come up with, and you should be able to use both blades. So you need to practice with both blades and be proficient because you need to have all the tool options possible. Blade size in adults is determined generally by your experience and how their patient size has fit with blades for you in the past. For children, you'll use your device, your app for the pediatric section, and it gives you an airway once you put in the patient's age or height. The term stylet is a device, or referring to a device that is a little bit more rigid than the tube itself, and it holds the tube shape. And when we're looking at getting our tube ready for intubation through the orotracheal route, generally want to have the hockey puck. And so 15 millimeter adapter, and then we've got our tube, and it should go straight. It's basically straight to cuff. And then at the point of the cuff, you'll bend it like this, and that gives you a lot of manipulation in that airway. And so the stylet fits inside here, and then you bend it, and it's again semi-rigid as a wire, so it holds it in place. Something very important is to identify that this stylet should not ever never pass the tube, because it's going to poke up against all the structures. And to ensure safety, we're going to make sure that it doesn't extend past the Murphy's eye. So if we zoom into this part of the tube here, there's a bevel and the Murphy's eye, and so your stylet generally stops there. McGill forceps, just as part of our equipment, is utilized to remove foreign body airway obstructions, but it can also be used to guide the tip of the ET tube if we have a hard time with the angle in introducing that tube into their airway. Directly visualizing the tube is what you've practiced most recently in lab. So that's using a laryngoscope blade to illuminate and visualize the tube and place it. So indications for this. So we're going to go through these different types of airways for intubation, and we're going to identify advantages, pros and cons essentially, and then primarily our contraindications and indications. So indications: airway control is needed because of an altered mental status or complete arrest. Ventilatory support before impending respiratory failure, so we catch them early, right? So this is going to be our projection into the future of their care. Absence of a gag reflex, specifically when the patient has an altered mental status. Traumatic brain injuries, unresponsiveness, impending airway compromise, so again, that's a projection. And then perhaps giving medication through that route. Contraindications: if the patient has an intact gag reflex, as soon as the tube goes into the airway, they're going to vomit, aspirate, and we've not done them any better. Intact gag reflexes, we do teach you to check the fluttering of the eyelash, but it's not fully reliable, but it's a start at some point. If the patient can't open their mouth because of trauma or some pathologic condition, we won't be able to put a tube through. If you visualize the airway and you cannot see the glottic opening, you should not pass the tube, because you do not know what type of tissue damage it's going to cause. And if you're overzealous and you're like, woohoo, I got the tube, and you pass it anyways, you'll probably end up tearing tissue. Positioning the airway is very important in utilizing the ET tube. When you're putting in our supraglottic airways, they're all blind. So now we have to actually visualize that tube by looking into their face, essentially, with the right blade and the right amount of light. So when we're doing this, we want to make sure that we've got a couple different positions. So when we're looking at this, it's got 3 axes. We've got the pharyngeal plane, right? So this is basically where our pharynx resides. So we've got nasopharynx. This is the back part of the palate. Uvula would be there, and then the oropharynx. Then we have the tracheal plane, and this is the plane that leads from this part of the airway into the trachea, and then the oral plane. And so what we're really trying to do is align these planes into a position so that the oral plane is going to transect the pharyngeal plane and the tracheal plane. And so the biggest one to work on is making our tracheal plane in line. You can see how beautiful that is in this picture. When we insert the device for direct visualization, we'll move this up out of the way, but this is very important. So putting the patient's airway into that sniffing position. Some ideas to think about. So the atlanto-occipital joint is the joint between C1 and C2. Atlanto is C1 and axis is C2. So 20-degree extension at that point, 30-degree extension at C6 and C7 with our short neck patients. So short neck means that our angle is not going to be easily attained. And then we want to elevate the head until the ear, until the tragus of the ear. So that's that little piece right here. The tragus of the ear is in line with the level of the sternum. And that would bring our trachea into a straight line. And then our head would be tilted a bit, so our axis would then meet. Note on inserting the blade. So this has got to have some finesse with it because you can cause a lot of damage, including broken teeth. And broken teeth now are an airway obstruction and something you just bought your patient. And when intubating the patient, we want to make sure that we're very methodical about it. So when we insert, we're going to insert the blade. So I'm just going to assume that you're a right-handed provider. We generally only carry right-handed tubes. So you learn as a left-handed person to use this in the right hand. So you're going to place the laryngoscope and the blade into your hand as you've been taught. I like the ridge of the palm to be up against this. And as you insert it, you're going to use the scissor technique and you're going to sweep this way, so you sweep the tongue out of the way. Instead of going straight into the airway, you won't find a lot of success. You want to sweep it gently from the patient's right to the left. When intubating, we want to make sure that we do not come up against the lips or the teeth, so this is a good insertion position. Probably, you can see the lights right here, so we're not necessarily ready to visualize the airway. Exert traction about 45-degree angle as you lift the patient's jaw. So a couple of things that I like to tell my students. When you're intubating, you want to be further back. This person does not have a good line of sight because if this was in the airway, the line of sight is down. That doesn't help us, right? Because right behind the trachea will be the esophagus. So this person should have a line of sight somewhere in this range. And so get down or elevate your patient, whatever it is that's going to allow you to visualize that patient's airway. Now, you want to make sure that your arm is a locked unit. It doesn't move in portions, and your wrist is locked. So let's put wrist locked. Because when we start tweaking, we don't want to move backwards. Flex that wrist and then start moving because we'll lose teeth. And once you get the device in, you've swept to the patient's left, you want to pick a position in the room basically that is the joint of the ceiling and the wall. And just act as though you're pointing or lifting it up in that direction, and that will give you essentially your 45-degree angle. This is a great picture. We do not see the lower portion of the airway, but we do have quite a bit here. So if we're looking at this, let me just kind of label the view that we have. We have our anterior and our posterior views. So this is as you would see when you intubate a patient. This is a camera obviously from probably a bronchoscope, but nevertheless it's the same. And so what we see here are the rings of the trachea. Yes, we see some soft tissue, and just imagine what's there. If you're looking at the anterior portion, this is going to be the thyroid cartilage, right? So the thyroid structure, and this right here is going to be the cricoid structure. All right, so that's inside the trachea. To the posterior, or on my drawing down here, would be the esophagus. All right, so what we have here, can you guess what that is? That big shiny structure, given my reference. All right, so this should be marked for you as the epiglottis. Now I want you to note, look at all the blood vessels here. Lots of blood vessels. All those blood vessels are very shallow to the tissue, and so they probably will end up fracturing and bleeding. We have our true vocal cords here. Now this is pristine. This is somebody who is probably well prepped for a surgery. We don't always get that. All right, caution on using the Miller. When you're using a straight blade, you should not use the straight blade to just bury directly into the esophagus and then back out. You're going to place the blade in, you're going to move incrementally forward as you sweep, and then you're just going to find the spot. Burying it down causes potentially a Mallory-Wise tear, which is a tear inside the esophagus near the trachea, unfortunately. It's also difficult. You should not be using the MAC as a Miller. That doesn't help a lot of times, but you'll find the right, with practice, you'll find the right mechanism. I added this in here for our lecture. It's the bougie. The bougie is a phenomenal device, and so you probably see it in your bag. And if you notice, it's like a really long catheters, I'm sorry, a stylet of some kind, and this would be the distal portion, so it's got that hockey puck appearance. Very large device, but the way that this works is you insert it into the patient's airway. It goes into through the vocal cords. It's very small. It's not as big as your AT tube, and when you move this thing, the gum bougie, the hockey pick portion, on the inside of the airway, you'll feel bumps. You'll feel little ticks as it goes through, and that tells you, that's confirming that this is in the correct spot. Here's the use of it. Once you're inside that location, you would just feed your ET tube on top, slide it in because you know exactly where this is, inflate, and then remove the bougie. Never insert the tube. This is more of a Wisconsin blade here that we see versus a true straight blade, if I'm not mistaken. It's a little bit larger circle and tighter opening. So this is purely for visualization. Do not insert the tube into that space. The tube should be inserted here, and the reason being is if you do this, and this is visualization, and the tube's blocking, you may not get your tube. It might not go into the airway. After you insert the tube and you're visualizing it past the vocal cords, insert generally on the tube until you reach a black line, and the black line signifies that it's up against the correct position, and that's roughly about ½ an inch beyond the point of the vocal cords so that the cuff can inflate fully and hold it into the trachea. Now, the specific steps that you're going to go through, I'll let you read about in your notes here. But I will come to the confirmation of the tube. So we got a few things. Number one, you should say out loud, "I see the tube." Right? I see the tube passing through the vocal cords. That should be said out loud for the rest of your team. That is confirmation. You should auscultate, and you auscultate the lungs and the stomach. And personally for me, I will start auscultating the stomach, and then I will move to the lungs, because if the stomach gurgles, I'm in the wrong spot. Whereas I have to give a few breaths if I go to the lungs first and then make my way down into the stomach. Capnography, which we will talk about soon, is very, very important in confirmation. Then we have these esophageal detector devices, two of which I have identified here. So this is the bulb detector device, and then this is a large syringe with a very specific type of connector. Well, you guessed it, 15 millimeters, and this is going to be the syringe type. So the theory behind these is, when you insert this, you're going to want to make sure that the syringe is fully plunged. The plunger is all the way down before you attach it, or before you attach the bulb to the the endotracheal tube, you're going to remove it, squeeze it so that it is closed, right, so it's collapsed, attach it, and then release it. If it is inside the trachea, this will open freely. If it's inside the trachea, this will pull back freely. But if the distal portion of the tube sits in the esophagus, when you try to pull back on the syringe, what's going to happen is you're going to get resistance because it's a collapsible structure, and the negative pressure will cause the esophagus to collapse around that syringe. Likewise, the bulb will remain collapsed. Misting in the tube is useful. It could be misting from the belly as well. So we're using multiple conformation techniques for our tubes. We're going to inspect the device and also note how deep it is in the airway so that we can know if it moved over time. And then SpO2, and we're also inspecting for chest rise, gentle chest rise with our ventilation, and that it was equally bilateral. All right, excellent. So you should be doing all of these things on your tube and also documenting all of these things. Super important for documentation. When securing the tube, you want to remember that for this device versus our supraglottic, you never let go of the tube. When you take your hand off the tube, it could move, become dislodged, and that could be the only chance you had at getting that tube. You want to keep the neck in line, and you're going to note the depth as I mentioned before, so you'll measure whatever the depth is, and you're going to note it in your chart. And this is going to be the length of the tube, so this is going to be in centimeters. Place the tube in the center of the mouth and insert a bite block. If you're using a commercial device, they usually have a bite block, so you may not need that, but an OPA along the side is going to be great, and then you'll tape the device. And there's a few different ways to tape it. The first thing you want to understand is when you're taping, you are not wrapping it around the neck by any means, so it should be taped around the tube, around the back of the head, and then some stabilizing tape by ripping it. Now that's something I just described, but you're going to have to see it in lab to kind of put it together. Another type of intubation is nasotracheal intubation. You will have an exposure to this in lab, and you'll practice multiple times as you go through the term. Now, nasotracheal intubation is very similar in most cases, unless you don't have an endotracheal, as it's called, but the same tubes. This tube is now going to go inside the nose, and it's going to pass through the posterior portion of the pharynx, and it's going to make its way hopefully into the trachea. Now remember, this is a blind insertion though, because you're not directly visualizing. So this can be difficult but not impossible. Indications for this are going to be patients that need an airway, but they are breathing spontaneously. And that's important because when you put the tube into their trachea, if they're awake, they should not be able to talk, right? Because we've put a tube in their vocal cords. If they can talk, we're in the wrong spot. And so what we end up using is this device called a BAM. And I'm going to draw it. It's actually orange, and it has a little piece here, and it is 15 millimeters. And it will connect directly to your ET tube, and it whistles as air moves in and out. And so once you're inserting this, and there's some steps in your skills drill, you're going to insert this, and as the whistling gets louder and louder, you're manipulating the tube so that it points directly to that area as you visualize it. Contraindications, apnea, we have a hard time getting that in apnea, head trauma, and mid-face fractures. So although this is trauma, you do need to be aware that it is contraindicated when a person has facial trauma, because we're concerned about a few things. One, further damage to the inside of the nose, which could cause a significant bleed, and also perhaps a basilar skull fracture in which the tube will go into the brain. Anatomic abnormalities, and so deviated septum, you'll have to be a little bit careful with that because one septum won't take the tube. Frequent cocaine use also changes the inside, the mucosal layer. You have to forgive me, it's very late as I prepare for this lecture. The mucosal layer is probably changed a bit, and that makes it a little bit more difficult to insert this tube. Advantages to the tube. So it can be performed on responsive patients without using RSI, and very, very useful. I like to think about some cases like a patient that I had that had trismus, so clenching of the jaw, from meningitis, so no facial trauma. And I didn't want to crack this patient right off as my first route, so I decided to attempt a nasotracheal intubation that was successful. Another area that was used on very often are COPD and your congestive heart failure patients. It is something you do need to practice on the mannequins, and it's a bit of a gift on how to actually do this. You don't have to visualize, right? So no visualizing. Mouth doesn't have to be open. No positioning because you're going to manipulate their head as you go. Patient can't bite down on the tube, so a tube block isn't important. Very easy to secure because you tape it to the nose basically and not the back of the head, and the patient might be sweating and diaphoretic. Disadvantages, again, blind technique, and bleeding is a complication that can occur because this huge tube is displacing nasal tissue. The equipment that you need is basically the same tube unless you have something called an endotracheal, which I'll write here. And the endotracheal, you'll have to see, has a little bit of a round ring with a string essentially tied to it, and it connects to the tip of the tube so that you can use that portion to bend the tube as it moves towards the airway. And this is for a nasotracheal intubation, obviously. And that would be our endotracheal right here. Digital intubation is another means of intubating a patient, and this is a blind intubation generally in its consideration. So you're going to directly feel. So it's blind, you're not visualizing, but you're palpating. So what ends up happening here, the gist is you're going to reach into the patient's throat. You're going to find the epiglottis and the glottic structure. You're going to pick it up and move it out of the way, and then slide the tube down in between your fingers. Pretty amazing. Indications for this, and there are some unusual circumstances. You would not want to do this over laryngoscopy. If you have equipment failure and you can't actually visualize that, but you got to get the airway, that's an option. Patient could be in a confined space in which utilizing the laryngoscope is going to be detrimental to being successful. It may be actually completely impossible. Patients that have a short neck or are obese might be a little bit easier to use this on because visualizing is very, very, very difficult in those patients. If you have a lot of secretions in the airway, you wouldn't be able to visualize, so that could be a problem, a thing prompting you to use this. And if the head can't be immobilized because of, or can't be moved because of immobilization, you may need to consider this. Very difficult to do on pediatric patients, so we don't recommend it. The state of New Mexico obviously doesn't use pediatric intubation, but because of the space and the size of your fingers, it would be very, very difficult to do. Absolutely contraindicated. So absolute contraindications include a patient who is breathing, not deeply unresponsive because you're putting this hand in their mouth and you don't want to have them bite down. Oh, also your PPE could get cut, so be very aware of that. And if the patient has an intact gag reflex, we generally don't shove tubes down their throat. Disadvantages to this are going to be the risk of being bitten and the risk of exposure to infectious disease because the teeth will cut through your glove, and if they break your skin, you may get what they have. Complications to this would be misplacement of the ET tube. The bite block could be, unfortunately, excuse me, could cause lip and tooth damage. And if it's not performed correctly and it takes a long time, the patient will undergo hypoxia in that process. Equipment for this are going to be the same, essentially, except for the laryngoscope because you're not visualizing. So you'll use a stylet. Untitled CO2 will be useful, or soft gel detector devices so you know you're in the right location. Appropriate devices secure the tube. And then I would also recommend that you consider looking at your protocols of means of perhaps ensuring that this patient remains sedated if they start to wake up. Transillumination is going to use a bright light inside the throat, and so when you're inserting this, the visualization is seeing the light in the center of the throat. It looks a little bit like when you place a flashlight on your hand and you see the pink and red tissue basically from it. So that's the device. If you can see the light, then it went into the trachea. If you don't see the light, then it probably went into the esophagus, right? Because the trachea would be blocking that view. Not a go-to device for the first attempt, but could be something you're going to utilize if you carry it, as other devices have failed. Contraindications, always back to our gag reflex. Airway obstruction, because we're not visualizing, right? So laryngoscopy might not be present, and again, may be difficult in those patients. Pediatric patients are difficult because the stylet has to fit inside this tube, and the tube, as you can see in this picture, is a little bit bigger because of the light, but the stylet is where the light is coming from. So it's reusable as long as it's cleaned. Advantages: no visualization. You do have an external visual parameter to confirm the tube. When you're dealing with patients that have spinal cord injuries, it's very safe to use because you don't have to manipulate to get the right angle for viewing. Disadvantages: it is very expensive, so very few places actually carry it. And you need to really be proficient with this, but in the daylight in bright rooms, turning off the lights to do this is difficult, so you may just grab if you have this device, you may grab a blanket and put it over your head so that you can kind of close off the ambient light. Some more notes on transillumination that I'll let you read in your reading assignment for time's sake. Retrograde intubation. So if we think about retrograde, that means that we're moving backwards in our intubation. When you're intubating from the caudal side down towards the feet, and so the cephalic down towards the caudal side, so from superior to inferior. With this, you're going to move in an opposite direction. Not that you put the tube in the opposite direction, that would be completely worthless. But we're going to utilize a guide wire and a needle. And the needle is going to go into the cricothyroid membrane, and the guide wire is fed through, and we're basically inserting this needle upwards towards the mouth through the thyroid membrane, cricothyroid membrane, and we feed that guide wire until it comes out of the mouth. Once it comes out of the mouth, you will remove the needle and leave the wire inside the airway. You'll start to feed the tube down the needle, and as you get into that spot, you'll remove the tube and you're in the trachea, right? Because if you put a needle through the throat, you end up in the trachea. Indications include upper airway obstructions, where visualization is very difficult, copious secretions inside the airway, not something we go to right away, so perhaps other mechanisms have not worked very well. Contraindications to this: it's something that takes a lot of practice, and the equipment is not necessarily out there in a lot of trucks, so it may or may not be available for you, but something to be considerate of National Registry. Unrecognizable or distorted landmarks of the neck, so not visualization of the airway, but of the neck. If you cannot feel the Adams or Eves apple and you move down into the cricothyroid membrane, if you can't feel that, then you're not going to be successful. So contraindications: hypoxia. It takes a little bit more time for this to actually get through. Could cause cardiac dysrhythmias and mechanical trauma at the neck, and there could be some bleeding associated with it depending on your technique. The intubation through this route can also, the pain is one portion, can increase intracranial pressure if we have a patient that is suffering a traumatic brain injury. Skill Drill 15-22 is a good reference for this type of intubation. Face-to-face intubation is unique. So if you think about you're intubating a patient laying down on the floor, you'll be at their head side looking down, and that's how you visualize to go into the airway. Sometimes this is not necessarily something that can be done. And so a good example is a patient trapped in a car, and extrication is happening, but the patient has not been extracted, and they won't be extracted anytime soon. When that occurs, if you have to get an airway on an unconscious patient, you can use the face-to-face method. So you're sitting in front of them face to face is how it goes. Head is stabilized, they're not in the sniffing position. And the way you're going to do this is basically utilizing the ET tube backwards, and laryngoscopy primarily backwards. So if you're right-handed, as I pointed out, you'll hold it in your left hand, the laryngoscope blade, and you'll sweep from right to left. When you're face to face, you're basically going to hold the laryngoscope in the same position of the patient's face and mouth, sweeping to the patient's left, but you'll have to hold onto that device a little bit differently. So sometimes, specifically if you're right-handed, you'll place the laryngoscope blade in your right hand. You're going to sweep across as if you're kind of doing it normally from patient's right to left, and then the tube will be passed through this space. Visualizing is difficult, but can be done. Some terms for us as we move into a few more discussions on intubation. So a failed intubation is when we have not maintained oxygen saturations with our attempts to place it, or we have failed a total of 3 attempts of intubation. So misplaced or 3 attempts. At this point, we're done. And so we have to change something, because if we kept doing this over and over again without changing something, we would actually fit the criteria for being insane. And so oftentimes, if you're working on a truck, you may not have a paramedic that you can switch this off to. So you change your tools, you change your tube size, and other mechanisms. But don't forget that you could use rescue airways or very basic BLS airways, supraglottic airways, if the damage isn't so severe, to take over and get this intubation. If intubation is not working and the airway is not closed but a little bit patent to some degree, we just need to get ventilation because they're unconscious. Going back to BVM and securing with oral airways or nasopharyngeal airways is completely appropriate in the failed intubation. I should note, do not sit in the parking lot of UNM trying to get a tube before you go in, just so you could show that you got a tube, even though it was really hard. Tracheobronchial suctioning is it's very similar. You use a device to suction, very loud, obviously, as the process is turned on. But this is utilizing a soft tip catheter that's going to go into the ET tube and remove secretions, blood, whatever it might be. You don't want to use this if you don't have to. And the reason we don't use this if we don't have to is because this is a sterile technique. We are introducing a foreign device directly into the patient's lungs, which is a great breeding ground for some nasty infections. So we want to make sure that we're only doing this if absolutely necessary. Another thing is we have to have a cardiac monitor on these patients and oxygen saturation, so we can monitor that as we're essentially doing this. And remember, suctioning takes away oxygen, and taking away oxygen can send you into arrest. Pre-oxygenation is important for 2 to 3 minutes before we actually suction this airway, if at all possible. Very specific steps and measurements, so I'll give you that as skill drill 15-23 to review at a later time. Field extubation may be something that has to be done, and if it is, it's a difficult situation to deal with. But we're removing the tube from an intubated patient. So we want to make sure that when this happens, we've tubed them, and now we're in a position where they woke up and they're combative, they're going to pull it out on their own. You need to contact medical control or follow your local protocols. Probably contact medical control, the receiving facility, to discuss removing this tube from the patient. Risks of this are going to be basically taking it out too soon, laryngospasm because the larynx has been held artificially open and not able to move. Also upper airway swelling, and perhaps if the tube is removed could cause some vomiting as well. Something to be considerate of. If you are taking out this tube, you need to make sure that you can get this tube back in if necessary, or you have a plan. So this is one of the scarier situations as a field extubation. All right, as we extubate, this is probably a patient who has some level of consciousness regained, so we want to explain this process to the patient so that they're aware of what's about to happen. You want to have your patient sit upright as far as possible, so high Fowlers, if not more forward. Have everything ready for suctioning and ventilation just in case, and also have all your tools ready for intubation as well. From this slide, I've let you read a few lines here with some moment of silence, but on exhalation is when you want to remove this tube, because if they're breathing in, it's a little bit harder and they may actually breathe in some secretions or aspiration. Pediatric intubation is covered very briefly here. It will be covered a little bit more in your PHTLS block at the end of the term. Some things to note, Table 13 identifies the differences between adult and child airways. Child airways are a little bit smaller proportionately than the adult. Also, the epiglottis is made of a lot of soft tissue. It's much larger, and that's what leads to epiglottitis being fatal in our patients. Although New Mexico does not allow this to occur without special skills because it was removed from our scope of practice, you do need to be aware and able to practice these intubations on children. Remember, the size of the tube can be identified generally by the pinky of the patient, or using your device's PDStat app. For children, we use a different laryngoscope blade. It's not the same blade. Obviously, it would be if they're an older child, but for small children, we use a different size blade and different size handle as well. And they don't always interchange between the handles. The pediatric handle is designed as such to be a little bit more maneuverable. It's lighter and decreases the chance of fulcruming. Here's just some ideas on how to identify the length of the tube that we're going to utilize and the right blade. So as you can see, premature newborns will get a blade 0 straight blade, and we don't use curved blades until we get into the adolescent, which is basically an adult size patient. Some things to memorize on this slide. So we do use the Broslow tape, or your equivalent obviously is the PDStat app on your iPad, and that will give you, based on the patient's height and or weight and age, the correct size tube that you'll be starting with. And again, when we're intubating somebody, we have a size. We're going to have the size we need, and we're going to have what else? Great. One on either side size, extra tube just in case. These formulas here are important for memorizing the size of the tube. Essentially the same answer will get to you. You choose the one that you like the best. As mentioned before, uncuffed ET tubes are primarily utilized in small children. Cuffed tubes will be utilized about 8 to 10, or essentially the onset of puberty. You're certainly using cuffed tubes. Uncuffed tubes can be a little bit better for our patients because of the size of the airway. Cuffed tubes will cause a little bit of damage to the tissue, and when the cuff inflates, it puts pressure on the tissue, evacuates blood from that tissue, and can lead to necrosis. Depth of tubes. This is in general and not just for children. So something that we need to identify is that you want to make sure that the depth of the tube, again, is 2 to 3 centimeters beyond the vocal cords, or a lot of times there's a black line on the tip of the tube that you're going to insert. The tube insertion in adults and children should be 3 times the diameter of the tube. So we know generally what depth we're placing this tube. Now, there are some drugs that are utilized in emergency medicine to help us with intubation. Now, there's means of using medications to allow us to intubate when we otherwise would not be able to without these medications, to just get the first tube. And then there's drugs to maintain our tube during our transport. So in New Mexico, rapid sequence induction, sometimes called rapid sequence intubation incorrectly, is a special skill reserved for generally flight services and critical care transports. Our goals in utilizing these medications would be to decrease discomfort of the intubation. It is painful, and patients can feel pain when they're unconscious, depending on their level of unconsciousness. We want to make sure that we don't have complications like losing the tube because the patient woke up and flailed around. And then sometimes we have to essentially be more aggressive with our patients who refuse to cooperate. Now, leaving some of this, most of this, to the pharmacology lecture, I'm going to cover just briefly some of the drugs, their names and their classifications, and why they might be better to use in one case versus another. So sedation and intubation reduces anxiety. It does induce amnesia, so the patient does not remember it. There's a few things you should know about intubating patients. So number one, I just want to kind of throw out something hopefully you've heard before, is pain is a vital sign. And it's usually the sixth vital sign in nursing, right? So pain is important. It's subjective and sometimes objective based on their response, but a patient should not be in pain, and they should not remember some of the things that we do to them. In fact, in the ICU, those are goals of treatment. They shouldn't be in pain, and they should not remember their stay in the ICU, because there's some rough stuff that happens to human beings in that case. Under sedation could lead to, if obviously not enough medication, could lead to some complications of gagging because it didn't remove it. Partial amnesia, where they're going to remember some things, and maybe the patient is not fully cooperative or perhaps still combative. Oversedation has its own problems as well. So undersedation seems to be a little bit less in some ways, but if you can't get the tube maintained and that gag reflex is still causing gagging, it's a concern. Oversedation can cause general anesthesia. And so sedation is different than anesthesia. Anesthesia is rendering a person completely unconscious. Sedation is decreasing their level of consciousness so that they are a little bit sleepy, but generally can be somewhat awake, right? Conscious sedation as an example. Anesthesia is not our goal in our scope of practices, so we need to make sure that we're not inducing that. Loss of airway reflexes that are protective in case perhaps the tube is removed. Respiratory depression obviously is a big concern with sedation. Respiratory depression may not be beneficial. Complete airway collapse could occur, especially in children with the wrong drugs. And these drugs do have an impact not just on the airway, but on the overall vital signs and hemodynamic stability in our patients. Table 16 from your reading for airway management, so chapter 15, kind of shows some of the medications that are within these drug classifications. So butyrophenones are sedatives, and they include one of the most kind of referred to drug of this class is going to be Haldol. And Haldol was used in emergency medical services at some point years ago, but they found that there were some negative impacts. Specifically, we had some changes in the QT segment of the EKG, which led to some cardiac dysrhythmias. Benzodiazepines are common in our scope of practice: diazepam, Valium, and Versed. Barbiturates, we do not have a lot of barbiturates within our scope of practice, perhaps for interfacility transport or special skills for flight medications or flight meds. But we do have them as a classification of sedative hypnotics, just as we had before. And the sedative hypnotic, the hypnotic part is amnesia. Sedative is reducing anxiety. Narcotics can produce a similar effect, and notice that we do not have morphine on this list, but we do have fentanyl. And then non-narcotic, non-barbiturate sedative hypnotics really fall in one prototype medication, that's etomidate as that prototype, which we will talk about. Flight services use etomidate, and ketamine not included in this, in their maintenance of patients or in decreasing anxiety in some of these other areas. So remember, this classification included a specific drug. Let me get this back up here. Haldol. And so not very common to see in EMS in New Mexico, but something to be aware of. It's useful in some ways. It does not produce apnea, so that's good. So respiratory depression is not a concern. It is a sedative, very effective, but it is not a amnesiatic, which produces amnesia. Very little effect on cardiovascular system as far as your BP, but it does have an impact on electrical conduction of the heart. And it's not recommended to induce anesthesia. So again, our goal is not anesthesia in our patients. They bought their tube because they were already probably unconscious. Benzos, important drugs to utilize, have a lot of different functions and very, very effective. So sedative, hypnotic, check. They'll produce some muscle relaxation, which will help us with the patient moving around and trying to pull the tube. Mild sedation. Anxiolytic and anti-seizure medications are their more common use, and they can provide anterograde amnesia. When we're dealing with our patients, if we're trying to reach muscle relaxation, although benzos will produce that for us, neuromuscular blockade is something that is utilized more frequently than the benzos. Potential side effects from benzos, they do have an impact on cardiovascular system and ventilatory system. So these patients may have a change in hemodynamic status. So we want to be very concerned about patients perhaps in shock with these medications. Flumazenil is the antagonist, or essentially the antidote of sorts for benzos if the patients are overdosed. Excuse me. Barbiturates, again, as we talked about, so thiopental is a common medication. They do have different levels of action and onset, how long they last and how quickly they work. They do generally cause respiratory depression and a drop in blood pressure, and that blood pressure drop could be irreversible, leading to death. Narcotics, you're likely familiar with the term, and we use antagonists if we're dealing with things at the basic level, and of course the antagonist for this is going to be naloxone, and it's actually not even just a narcotic, it is a narcotic antagonist, it's a narcotic competitive, because it competes for those receptor sites. These do cause respiratory and central nervous system depression, and they relieve pain, so analgesia, and a side effect is sedation. All of the other drugs we talked about before do not relieve pain. So if your goal is to relieve pain with this as well, pain of the tube, so on and so forth, let your protocols guide you, but the opioid may be a better choice. Remember that fentanyl has a very short half-life, quick action, and is pretty powerful as a medication. So less impact on the cardiovascular system, but still some when compared to morphine. Non-narcotic and non-barbiturate classification includes our prototype etomidate. Etomidate's a very commonly used drug in flight services, but not so much on our tools of the box inside the truck. So it's a hypnotic sedative, so kind of within that same realm of no analgesia, but being able to sedate. It is used in induction, so that would be RSI a lot of times, because it produces general anesthesia. And so anesthesia is a disconnect from the rest of your body. Nice thing about this is it's fast acting in short duration, so if there's a negative effect, you turn it off, and it generally will reverse very quickly. Little effect on all of these things. So when we think of a patient in trauma, this sounds like a really good drug to utilize based on those kind of parameters. Now again, the depth of these drugs is going to go back to Kathy and her class. A really nice impact, and this is kind of comparing etomidate, specifically this line, comparing etomidate to morphine. So no histamine release, so our blood pressure isn't going to change the same way, and little to no risk of bronchial constriction. There is one thing that comes up, that's a high incidence of myoclonic muscle movement, so specifically large muscles moving around. And it's found useful in patients with coronary artery disease, increased ICP, and borderline hypovolemia and hypotension, which really, I think hypovolemia we can kind of leave to the shock, but we would measure it as hypotension. Neuromuscular blockade is here in our lecture. Not something that can be utilized on a regular push for our patients, but something that is in New Mexico a interfacility transport for paramedics to generally maintain sedation over a period of time. National level, MPH-TLS do talk about RSI as the next step, so neuromuscular blockades we do need to cover. So essentially what ends up happening with the neuromuscular blocking agent, they're going to impact the response of our motor neurons communicating from the brain to all the muscles in the body. And so once they're given, they produce paralysis, and it's generally under a minute that the person will go into paralysis. So we do need to point out that this paralysis that we're discussing, it does include intercostal muscles and the diaphragm. So that means they will go into apnea immediately. This is not a sedative. These are not sedatives, as we see with their no effect on LOC, and they are not analgesics. So I do need to kind of point out when this drug is given, you take care of their airway, and if their airway fails, you caused it because they were breathing before you gave the medication. If they're not breathing, they're fully unconscious, there's no need to give a neuromuscular blockade agent or any of the other things because they're unconscious, they're not fighting you, and they are probably deep enough in their disease or coma that they're not feeling pain. Now, when we give neuromuscular blockades, they're awake, they're breathing, we paralyze them, and so they are fully aware of what's going on around them. They're fully aware of the idea that they're saying to their body, please breathe, and it's not breathing. They also can't move their mouth and speak, so they're not able to communicate with you whether they have pain or not. And so it's important that when we give these medications, generally sedatives are also given so that they don't remember our hallmark, and analgesics are given with these medications so that they do not feel the pain of everything else. So if you can try to imagine being stuck in your body, fully aware, unable to communicate, you're paralyzed, you're freaking out because you're not breathing, and you're relying on somebody to put a tube in you, that essentially you're fully awake and feeling, which is pretty painful. Here's a list of common paralytic medications. I want to point out just a difference here, specifically in succinylcholine. So as we see these lists, right, we see depolarizing and non-depolarizing. So depolarization of the muscle is what we're referring to. When succinylcholine is given as a neuromuscular blockade, it initially floods the synapses, right? So depolarization floods the synapses, and the patients, before they go into paralysis, will experience tremors, muscle tremors as they move through that depolarization phase, and then they'll stop with the tremors and be paralyzed. Succinylcholine is chosen a lot of times in RSI because the medication is generally fast acting and doesn't last very long when removed. Now, these other drugs, though, they do not depolarize, so they just invoke immediately the onset of paralysis, right? Now, these all last different time periods as needed, so this is about an hour, a little less than an hour here as needed, and in some cases you'll give a non-depolarizing agent before you give your depolarizing agent. Downside to succinylcholine is it needs to be refrigerated before administered, so you have some issues there in transport. So I ask you some questions before we move on to rapid sequence intubation. So induction, I'm sorry, even I got caught up in it. You are dealing with the patient, and the patient is someone you're considering RSI on. And as you're preparing this patient, they're presumably awake, and not able to tolerate a tube, and perhaps nasotracheal intubation wasn't indicated. So you start ventilating your patient. As you ventilate the patient, you have poor ventilation, poor ventilatory compliance, and so you essentially can't BVM your patient very well. So if you can't BVM your patient very well, should you RSI? The answer is no. If basic airway maneuvers are not going to be successful, you do not want to put the patient into a condition in which you stopped all breathing, you're now responsible for their airway, and when you try to ventilate for them and do all these things, it fails. If you knew that beforehand, that would certainly be detrimental. So another question, can you RSI if you're going to be unable to pass a tube, meaning that this is perhaps a really difficult airway, Mallampati score of class 4, very difficult to see, they don't pass the 332 test, you're really concerned that this tube might be really difficult. Should you do an RSI? The answer is no, you should not do an RSI because you're taking away their ability to breathe. We need to secure their airway. If you can't secure their airway, you're going to have a problem. Can you RSI New Mexico's scope of practice as it is as a street drug? The answer to that is also no. We are not able to RSI New Mexico without special skills, so we do need to be aware of it but not utilize it. Here's another question for you. The patient is unconscious, unresponsive. Should you RSI that patient? No, they're unconscious and unresponsive already. So RSI, rapid sequence induction. Rapid sequence induction. So we're inducting basically paralysis and anesthesia in this case, and then we're intubating afterwards. So intubation is not necessarily part of it. It's in the title. This should be a very calm, well-resourced procedure that goes smoothly and creates very rapid sedation plus paralysis, and then you intubate. But you have to be in control of the situation. So this is generally used for patients who are unable to cooperate as one area, but can also be used in specific patients that may be not cooperate as in, they're being a jerk or they're combative for alcohol reasons. These are patients that are probably combative for a brain injury or some underlying disease process. So very, very important that you explain what's going to happen to your patient because again, they are conscious and awake as these things happen. So reassure the patient that they're going to get through this. Tell them that they won't be able to move, they won't be able to speak, and they will stop breathing, but you're going to take over the breathing for them because they're going to be stuck in their brain. It's almost like being stuck in super locked in syndrome. You do want to apply cardiac monitor and pulse oximeter and have all your tools ready before you even start this process. An essential portion of this is going to be an IV in place, but you need all of your backup stuff so that if this goes wrong, you have all the tools immediately beside you because sometimes it goes wrong and patients can die. Adequately pre-oxygenate these patients. Again, this is somebody who's still a bit awake, so we may be able to get some good pre-oxygenation for them. You want to make sure you're doing this again so that we can increase the time that we have to insert the tube before they start desatting. Remember, they stop breathing completely, so they're going to desat. When you're dealing with a patient that can breathe on their own and it's adequate, you can use a non-rebreather mask to get there. If they're not, then you need to likely consider using high flow oxygen with the BVM. Pre-medication, so we're kind of seeing there's a little bit of a set of flow here. So we've got pre-oxygenation, pre-medication, so there's going to be about the six P's is what you'll learn later in next term. So when we're dealing with our patients, we got to select our drugs within our scope of practice and within our allowable protocols and choosing the right drugs for the condition that our patient led us to with RSI. So if, excuse me, if we do not we do not pre-medicate, we do not prepare our patients, they likely will have a bad outcome. So when we stimulate the glottic opening with intubation, it causes irregular heart rates and can increase ICP, which is a problem if a patient's suffering ICP for maybe medical or traumatic causes. When we're giving medications, if you're choosing succinylcholine as your initial drug for fasciculations, that's the term that is there for the tremors, you want to give the non-depolarizing drug first so that the succinylcholine will not cause the fasciculations. Atropine sulfate is often administered to the patient because it will help decrease the potential for bradycardia while we're going through this process and when we're intubating the patient in a paralysis state. So the next P is paralysis when we're administering the drugs. So we generally will induce a analgesic, some type of sedative, followed by the paralysis. So in the rapid sequence of these drugs, we want to make sure that they're sedated and pain-free before we stop their breathing. Of course, they were communicated with these drugs. So when you give these medications in order, the neuromuscular blockade should be the last medication that you give as you get ready to intubate. So one of the best ways to prepare and know that you're ready, because as soon as they go flaccid, you want to start your intubation. You have all your tools ready, you've got the laryngoscope in your hand. What you're going to do is put your finger on, you're at the head side of the patient, so of course in the right position, and all of those things are your control, right, because you want good outcome. You put your thumb on the mandible, kind of from the cheek side or at the bottom or at the very front of the mandible. And as soon as you push down, as soon as the patient is paralyzed, the thumb will push the jaw very, very easily because the mandible will then suddenly become flaccid. Apnea will ensue, and that's our sign to intubate the patient. Here are some sample steps from chapter 15 and table 18. So just some highlights here, right? So we've got some medications administered. So we can point out, so pre-oxygenation 100%, 2 to 3 minutes as we've talked about before. So remember our oxyhemoglobin dissociation curve. Administer defasciculating drugs, lidocaine and atropine as directed in your protocols. And you would also want to make sure you're administering your pain meds and sedatives. Administer the neuromuscular drug. Put your thumb on all your equipment's obviously already ready. You put your thumb on the jaw. Once the jaw relaxes, you intubate your patient, confirm, and move on. Okay, that wraps up a pretty monster lecture on how to perform many different variations of intubation that you'll now be taking with you into the lab. Up next will be surgical airways, so we'll take a very brief break before